Welcome to this brief introduction to the Medicaid program. Medicaid is a governmental program designed to cover the healthcare costs of people with disadvantaged economic situations and of disabled people as well. My name is Jim Pacala. I am a family physician and a geriatrician, and pleased to present this brief overview to you today.
I have one financial disclosure. I am the chairman of the board of UCare, which is a health insurance plan in Minnesota, and UCare's business does operate in the Medicaid space, but I do not believe it will have a significant impact on the content of this presentation and my comments. Okay, the two big governmental health insurance programs are Medicare and Medicaid. You've already learned a little bit about the Medicare program. Today, we're going to focus on Medicaid, but it is important to understand the differences between them. Medicaid is a program designed for folks who are economically disadvantaged and also disabled. And it is a partnership between the federal government, the Centers for Medicare and Medicaid Services, or CMS, and the states, which in our state is the Minnesota Department of Health. So while Medicare is a federal program, Medicaid is both a federal and state program. And there were nationally about 75 million enrollees in Medicaid in 2021. And you see the expenses there. 600 billion is spent on Medicaid and 800 billion is spent on Medicare. Do the math, that's a lot of governmental spending on healthcare. Now, there are some similarities between Medicaid and Medicare. Both were enacted in 1965. Both are entitlement programs, and they are overseen federally by the Centers for Medicare and Medicaid Services. But there are some key differences. Just to give you a little bit of a history lesson, in the early 1960s, the champion of Medicare was President Lyndon Johnson, who really picked up the ball from President Truman in the 40s to provide some type of national health insurance for older adults. And then at the last second in the 1964, when the Medicare legislation was being deliberated, a very powerful congressman from Arkansas named Wilbur Mills, who was the chair of the House Ways and Means Committee, proposed Medicaid and attached it to the Medicare bill. The financing of Medicare, again, is purely federal, and for Medicaid, it is federal and state. Here's a picture of Congressman Wilbur Mills. Again, this was back in the era of kingpin politics, and he was one of the kingpins of the House of Representatives. Incidentally, for you history buffs, Congressman Mills had a rather ignominious end to his career. I will leave it to you to research those details on your own. There are some other key differences between Medicare and Medicaid. In Medicare, the beneficiaries are virtually all older adults. Once you turn the age of 65 and you've paid taxes, you qualify for Medicare. It also covers some younger people who are chronically disabled. Medicaid is available to people of all ages, provided that they meet certain criteria. Those criteria and covered benefits are usually set by the states for Medicaid, and they differ by the states. In Medicare, it is a national program, so the benefits that you receive in Parts A and B are established by the federal government and are the same in all states. The enrollment criteria, again, for Medicare, our age and our disability, and again, that is set nationally by the federal government. In Medicaid, as I just mentioned, it is really based on your economic situation and your income, and as well as some other health and social criteria, and each state sets its own criteria. Let's talk a little bit about Medicaid financing. Here, first though, again, let's talk about Medicare. Medicare, about $800 billion is spent nationally by the federal government. And so the taxes that people pay in general funds of the government goes to the Department of Health and Human Services and CMS. That then gets doled out through traditional fee-for-service Medicare to individual providers and health systems. And also, as was talked about in the Medicare presentation, CMS will also capitate Medicare Advantage plans to provide care for those who enroll in Part C. In Medicaid, what happens is that CMS takes a large amount of funds from Social Security taxes. In 2020, it was about $380 billion, and sends that to the states. And then the states will kick in an extra, 220 billion or so. It's about a 65-35 split between the feds and the states. And the state takes the federal money and state tax money, and then it uses that to set up the Medicaid system in its own state. And that's how it pays healthcare providers and systems to care for Medicaid enrollees. Now, just a couple of things about Medicaid programs. Medicaid programs are Medicaid enrollees are largely younger families who have children. So if you look at the enrollees on the left, you will see that adults and children make up the majority of Medicaid enrollees. There are a small amount of younger adults who are disabled, and then a number of older adults are Medicaid enrollees. But what the state governments spend on their enrollees is quite different of a distribution. You can see that the majority of the Medicaid dollars are spent on people who are disabled and on seniors. And the amount that it's spending on seniors is for long-term care. Medicaid is the primary financing mechanism for nursing home or chronic facility care of older adults. Just a few more slides here on the situation in Minnesota. So Minnesota Medical Assistance is run by the Minnesota Department of Health. And the eligibility requirements in Minnesota are generally a little bit more liberal than you see in other states. To be eligible, you have to have a certain family status, a certain disability status, and a certain economic status. And so for a family of 4 with children, the threshold for medical assistance is if that family of 4 makes less than $75,000 per year, which happens to be 275% of the federal poverty level. So different states will set different percentages of the FPL or federal poverty level to determine criteria for eligibility in medical assistance. By the way, medical assistance is Medicaid. Whenever you hear one, it means the other. In terms of covered benefits in Minnesota, this is similar also in other states. It covers all inpatient and outpatient care. The deductibles and copays are generally $1 to $3. So it's much different than you would see in Medicare or in private insurance. The covered benefits also include eye care, eyeglasses, dental care, hearing aids. Again, those are not generally covered by Medicare, and those are differentially covered in private insurance depending on what type of policy you take out. There's a couple of infographics from the Kaiser Family Foundation. If you go on kff.org, that is a fantastic site if you're interested in health policy, to look at very, very good information and infographics, and I can't emphasize it enough. So the Kaiser Family Foundation is a big policy institute in Washington, D.C. Here's a KFF infographic that I got from Medicaid in Minnesota. You can see about 20% of the Minnesota population is low income. And most of those are covered by Medicaid or the Children's Health Insurance Plan, which is sort of Medicaid for kids. It also shows there who it covers. And like nationally, you have most of the enrollees in Minnesota who are adults and children, and the minority are elderly and disabled, but they use a disproportionate share of the Medicaid dollars. The majority of those dollars are used by older adults and by people who are chronically disabled. Much of that Medicare spending you see on the right goes to long-term care. And then when you see there managed care 46%, that's how the state manages a lot of its Medicaid population health systems. They will contract with health plans to set up health networks for Medicaid enrollees. And then the state then capitates those health plans. So it's sort of like a Medicare Advantage situation where the ultimate payer will capitate health plans to pass on the financial risk to those health plans to take care of Medicaid patients. So finally, this is the last slide. Medicaid expenses are doled out disproportionately to the disabled, disproportionately to older adults, and disproportionately to funding long-term care. Now that makes sense because those are expensive and necessary and humane uses of the healthcare dollar. That is the end of this presentation. Please view the next presentation on end-of-life care and the Medicare hospice benefit. And thank you very much for listening.